Well, welcome, listeners and viewers, to another in our series of interviews with the experts. I'm Malcolm Bell, your studio host today, and I'm joined by my colleague, Dr. Katie Young, whom many of you will remember our discussion with her quite a few episodes ago on peripartum cardiomyopathy. Katie is here today to talk about pre-pregnancy risk assessment for the cardiovascular patient. She's an assistant professor of medicine and medical director of our cardiac OB clinic. So, Katie, welcome again, and thanks so much for joining us for this second podcast.
Absolutely. Happy to be here.
Yeah. So let's just start off with why we're talking about this. It appears that maternal mortality rates are twice that in the U.S. compared to other countries. And so how can we work to decrease maternal mortality rates here? And as you answer that or think about that, is this because this is primarily a cardiovascular cause of death? And so maybe just a little background here, and then we'll talk about how we can prevent this.
Absolutely. No, great way to introduce this topic. As we know, the maternal mortality rates in the U.S. remain quite high, and cardiac disease is actually the leading cause of pregnancy-related deaths. And between 1% and 4% of pregnancies in the U.S. will be affected by cardiovascular disease. And we know that there's an increasing population of those with congenital heart disease living longer and into adulthood and having children. But we also see an increase in pregnancies in individuals with acquired heart disease conditions. So that can be aortopathies, cardiomyopathies, coronary disease, and more risk factors, particularly as individuals are having pregnancies later in their life as well.
I mean, it's clearly alarming that our mortality in this country is so much higher than in so many other countries. And obviously many different reasons for that. And maybe that's a discussion for another time. But for today, we're going to focus on the cardiovascular causes. And I think you said, it also includes, hypertensive heart disease, preeclampsia. So let's just focus on the cardiovascular aspects here. And maybe just start off with telling our listeners and viewers, how can we estimate this cardiovascular and obstetric risk in these patients?
Yeah, preconception counseling is really an opportunity, I think, for us in cardiology to make an impact on maternal mortality. It's our opportunity to provide education and risk assessment. And this is going to depend on many things, including the underlying cardiac condition, the individual's functional status, their comorbidities. And so it's not always straightforward, and it has multiple layers. And really, this is best done through a multidisciplinary approach. So here, we really like to do preconception counseling in combination with our obstetric and maternal fetal medicine colleagues, so that we're assessing both the maternal cardiovascular and obstetric risk, as well as potential fetal risks. And really, our goal is to help identify those at highest risk who may benefit from an intervention prior to pregnancy, those who should be advised against proceeding with pregnancy, and otherwise those that maybe were told they were high risk, to actually let them know that actually we think you can have a safe pregnancy and this is your plan. And there are a few tools that we have available to help us estimate those risks. Prior to CARPREG, so CARPREG is probably the initial risk assessment strategy that was published in 2001. Prior to that, there actually wasn't a lot of guidance in this area. And since then, we've had the Sahara registry, there's been the ROPAC registry, and then CARPREG 2 as well, which was in 2018.
So, Katie, sorry to interrupt you. So, as cardiologists, we love these risk scores, don't we? And
yes.
So you mentioned 2 or 3 there. So just want to make sure everyone heard that correctly. So it's the CARPREG. I mean, could you just maybe spell that out? Because I'm sure the viewers would be Googling this straight away.
Yeah, so CARPREG, so CARPREG 2 in 2018. Now that's a risk index score, which includes a few clinical and echo parameters, and it identifies 10 predictors on a weighted scale, and so you develop a score. although I would say what we use most commonly is what's called the modified WHO risk classification. So World Health Organization risk stratification. And I would say this is probably the preferred and felt to be the most accurate tool for risk assessment. And how the modified WHO or modified WHO risk classification works is you classify the individual based on the underlying cardiac condition. So if you, a good table of this is available in the ESC 2018 guidelines, pregnancy and heart disease guidelines. But for example, there's a class 1 through class 4. Class 1 will be your lower risk patients. So that's someone with a repaired simple congenital heart defect like an ASD or VSD, someone with a simple arrhythmia such as some PVCs or an SVT, and then it goes based on category. So intermediate risk is modified WHO class 2 to 3. So that's someone with, for instance, hypertrophic cardiomyopathy. And then our higher risk lesions are modified WHO risk class 3 and then 4. And so those are individuals felt to be at highest risk. And what's great about the World Health Organization classification is within their classification provides recommendations on how often to follow individuals through pregnancy and guidance on where these patients should deliver. Are these is this individual safe to deliver locally, or do we need to look at them coming to a higher level of care?
Well,
So it's very
further. So this risk score, it comes out as a numerical score, or is it a categorical score? And if so, if it is a numerical score, is there a cutoff in which you're going to consider this person to be at low risk? And again, I'm thinking of the scores that we're all used to using for other cardiac conditions and other disease states.
Yep. So what's great about the modified WHO is it's a categorical risk score. So the individual gets placed into a category based on their underlying condition, and based on that, it provides an estimate: low, intermediate, and high of maternal, cardiovascular, and obstetric risk.
Okay. And then, as you said, 1 to 4% of pregnancies, may be considered to be at high risk. In terms of the predictive value or accuracy of these risk scores, I mean, where do they fit? Are they very robust or modest? When you apply this to a large population?
Yeah, and I would say the modified WHO is felt to be the most accurate, and it does have some prospective validation to it, and that's the risk classification score that I use and that we use in our cardio-obstetric clinic most commonly. We also
okay. So you've got those categories which you just described. In which ones of those are you going to counsel against pursuing pregnancy from the outset? So preconception.
Yeah. So this is an important topic, and this is really where I think again we can make an impact. And so, in thinking about it, you can think of your risk classification, WHO class 4 patients. Those are the highest risk patients. Those are the cardiac lesions, which we feel are not likely to tolerate the hemodynamic and physiologic changes of pregnancy very well. And so
maybe 3 or 4 examples of that.
Yeah. Yep. So those would be patients with pulmonary arterial hypertension, severe LV dysfunction or symptomatic heart failure, previous peripartum cardiomyopathy with residual LV dysfunction. And then the other 2 big ones to remember are the obstructive valve lesions. So mitral stenosis, symptomatic aortic valve stenosis, and then aortopathies. So these have various cutoffs depending on the underlying cause of the dilated aorta. But Marfan patients, bicuspid aortic valve patients with aortopathy, they have various cutoffs, and depending on that, we would advise against a pregnancy if an individual has those things.
Right. I know you mentioned mitral stenosis and aortic stenosis as obstructive lesions. presumably, though, you could take a step back and then think about, well, maybe we could fix this, relieve the
Absolutely.
obstruction, and then come back later with an assessment for uh, suitability or safety of pregnancy.
Yeah, absolutely. And and this is the opportunity to do that. And if the individual really wants to proceed with pregnancy, knowing that sometimes will influence us moving forward with that intervention to allow them to have a safer pregnancy.
Are there any disease states, Katie, that in the past that we thought were unsafe, to consider pregnancy, that now today, with improved medical therapy, we already talked about valvular interventions, that
Yeah.
now it would not be so we may not be so definite in advising against pregnancy.
Yeah, I think I can't think of a particular lesion or underlying condition that's maybe changed in the past several years, but certainly I think our knowledge surrounding how to best care for these individuals and knowing how to risk stratify them and who's at higher risk has definitely improved in the past several years. Absolutely.
So, just in the last few minutes here, I mean, obviously, we have electrocardiograms and
Mhm.
echocardiograms and things, but what other testing would you consider to be really important as you're assessing these patients preconception?
So absolutely. So baseline ECG echo, we love that in cardiology. But a few other important parts of preconception counseling, we use exercise testing quite a bit. So anyone with congenital or structural heart disease, we use that assessment of their functional capacity. And in general, achieving greater than 80% predicted is associated with favorable pregnancy outcomes. So it's a test of their symptoms. So we also look for arrhythmias, blood pressure changes, symptoms, but also their overall functional capacity.
Do
So
you do that with the oxygen consumption and imaging, or is it just is plain treadmill testing sufficient then?
I usually do pair it with VO2. I don't commonly put it with imaging. It's usually, but a VO2 component to it is very helpful. So, but even just a plain treadmill exercise test would be sufficient as well if that's what's available.
Okay.
Um, and then a couple other things again for the aortopathy patients, baseline cross-sectional imaging becomes very important as well. And I often obtain baseline biomarkers like NT-proBNP for my patients with cardiomyopathy or valve disease as well to follow through their pregnancy.
Are there baseline NT-proBNP measurements that would really alarm you?
It's more really in pregnancy, so in someone who's healthy, through pregnancy, NT-proBNP should remain normal. So an abnormal NT-proBNP would raise alarm and should raise alarm for, investigating for cardiac, concerns or cardiac contributors to their symptoms. So in someone with pre-existing disease, I think having a baseline value to know where they are, many of them, it will still be normal. But if it's a little abnormal, then you at least know where they're starting to follow through their pregnancy.
Any other testing that you want to inform us about?
The only other important components I think to highlight are genetics is very important as well. So a lot of these individuals may have uh, autosomal dominant or genetic conditions such as Marfan or hypertrophic cardiomyopathy. So having them meet with a genetics team to receive counseling for their offspring is extremely important. And all individuals with congenital heart disease that become pregnant should be counseled that their babies are also at increased risk of congenital heart disease. So that is part of our counseling, and they should receive that. And then we can't forget medications. We also need to review medication lists to make sure things don't need to be modified, looking for those that are safe or not safe to continue through a pregnancy.
Katie, this has been really tremendous. Our time is up here. As always, so you just are able to explain this in very clear detail. I think our listeners and viewers have really gained a lot of knowledge here. This is a very specialized area. and one that obviously is very, very important for families, and particularly the mother. And so really appreciate you coming back to join us, and I look forward to further opportunities to have you share your wisdom and experience.
Absolutely. Happy to be here. Thank you very much.